So good morning. I see that the audience is light this morning, but I'm sure that in the next 10 minutes they will be there. As usual, we have a guest, doctors from Frankfurt that will present their city, their work. I don't know what they will do. So it will be done by Professor David Leistner and Dr. Marco Ochs. So you are very welcome. It's time to present your city and your work. Thank you very much.
So, good morning, everyone. First of all, a very warm welcome to you and all the members of the European Bifurcation Club here to Frankfurt. And as you know, Frankfurt is not only a very, very lovely and a very dynamic city, it's also the heart of Europe. Why it is the heart of Europe? Because, and this was clearly determined a few years ago, it's exactly from the geographical sides, the middle part of Europe, and it's a part of one of the two rivers is separating Frankfurt in two parts, the part north on the Main and the part south on the Main. And if you go look very, very exactly to the Main in the part of Frankfurt, you will see there's also a bifurcation in, not a true, or maybe it's a trifurcation, but it's a bifurcation. And so it's a perfect, I think, a perfect decision from you to visit Frankfurt this year with the European Bifurcation Club. Frankfurt has a long history in interventional cardiology, and I think some of the guys who are in the room know this. Frankfurt was the place where the second PCI all over the world was done. It was done by Martin Kaltenbach together with Grünzig in 1977. I will come back to the first case in Frankfurt. And Martin Kaltenbach was really a pioneer for interventional cardiology in modern heart medicine, because he had the idea that the surgeon and the cardiologist could work very, very close together, finding for each patient the individual best therapeutic approach. And this was, for my impression, the beginning of precision medicine and heart medicine. And so this is nearly close cooperated with Frankfurt and the history of Frankfurt. This was the first cath lab in the University Hospital of Frankfurt. That was a very, very hard fight for Martin Kaltenbach to get this cath lab and to start these procedures as first center in Germany. And as you can see, this is the statistics of Grünzig. I think this was in 1978, about the first year of PCI. This is a slide of Bernie Meyer presented at a historic session at the German Heart Association meeting 5 years ago. And as you can see, Frankfurt was the second place all over the world where the most PCIs in the first year were done, with 76 cases in the first year. Back to the first case, why it is important. This was the first case, and not only the second PCI all over the world, also the first PCI of left main. And this is important because you're today here, it's the first interventional treatment of a bifurcation. And this was done here in Frankfurt by Martin Kaltenbach together with Grünzig in 1977. So this was one-dimensional start of bifurcation, stenting and bifurcation PCI. And so then the time goes on and the young guys goes on, and this is Marco Ochs, who is heading our interventional cardiology department, and he will take over and tell you what happened in the next years with the success and with the support of Frankfurt.
Yeah, thank you very much, Professor Leistner. I had the fortune here in Frankfurt to join the group of Professor Leistner and really get into precision medicine, precision bifurcation treatment. And our understanding for a long time was plain. we had an understanding of bifurcations that they are plane. And we looked at it mechanistically at a plane view. And this is what you see here, bifurcations, angles, and diameters we looked at from an angiographic perspective. And even our bench testing, mostly these days, is plane. And what we have figured out during the next decades, from 2003 mainly, where the first crush technique was released or published, until 2019, where several generations and further developments of bifurcation stenting techniques. We have learned from studies what bifurcation stenting techniques might be prognostically beneficial. And the next step since 2023, we know now that the image-guided precision PCI is also of prognostic benefit. We can rule out complications, stent edge dissections. We know if we have to treat side branches. We learn if we have to perform calcium modification. And October was a very important study which has given us an impression how prognostically relevant this new technique was, published by Professor Holm last year with the October trial. And what's coming next? We are very active also in the field of CT. We think that bifurcations, the reality, is much more complex than the plain 2D view. It's a complex 3D anatomy, and we have to understand and have to get a better idea how we can adopt our stenting techniques to these complex situations. Yesterday and today, the next session will address that also, is that complex anatomy. And I think that CT will be a key technique to address these issues in simulation, in bench testing. And we are very proud that starting from next year, Professor Leistner has managed to get a photon counting CT to Frankfurt. And with this new technology, we hope to move the field further forward. So from my side, also a very warm welcome. And I hope that we will have a successful discussion, fruitful discussion together this day. Thank you very much.
Thank you very much. I invite the moderators and panelists to take seats. So Lilian, Dr. Swamy, Fazila is probably connected, Stefan, no? Sit here. Perfect. And this is the first news session. In news session, we usually present what is hot out of the press or just going to be submitted. The first lecture is Key Concepts from EBC Angio-Guidance Consensus, Prof. Francesco Burzotta.
Good morning, everybody. So I have to start my presentation with specific disclosures. These are first that despite that this was angiographically oriented paper, I come from a center where we love intracoronary imaging, one of the highest imaging physiology rate in Italy from in the last 20 years. and we worked hardly to promote the use of intracoronary imaging, specifically in the field of left main and bifurcation lesions. So there is a background that moved EBC in this direction was the fact that, okay, we worked hardly to put the left main and the bifurcation as the one that received the class 1A, so we are happy for that, and we think that we contributed strongly in this direction, and you will hear soon that we are working to standardize the use of them in this field. However, what we also know is the fact that all over the world, this is very recent publication from a group of Americans that worked hardly to increase the use of imaging. They reached 20% actually. So many PCIs on left main and bifurcation, as a matter of fact, are done with no imaging actually. So it is not possible for us to say that, I mean, there is a theoretical world where everything works well and do not take care about what's going on daily all over the world. So there is also a reasonable theoretical background for angiography guidance that should be in our mind. Imaging is wonderful and may facilitate our life. However, it might improve clinical outcome only by facilitating the achievement of the best PCI that is feasible in the individual patient. So this means that there are conditions where you add imaging, at the end it is impossible to dilate a lesion. So it is possible that this at best may facilitate, and as a consequence, a perfect result, full stent expansion and apposition should warrant a good outcome to the patient, regardless of the fact that it is achieved by angio or imaging guidance. So this is a strong theoretical background to, let's say, do our best in angiographic guidance. So aim of the board with this consensus is the fact that was to promote the concept that anytime we are not using imaging, we should use the microscope as much as possible. So we know that we are doing something that is more difficult, we are not facilitated, and this requires dedication, probably more than a standardized image-guided procedure. So we need to be even more focused on planning and meticulously performing our bifurcation PCI. And we should not complete our procedure with doubts regarding the result we achieved, because the final result we achieved at the end is the one that will be linked to the clinical outcome of the patient. So the paper came out, there was a lot of discussion, and in that we standardized that the work starts before PCI, during PCI, and there is also the confirmation for at least an optimal angiographic result. What should we do before PCI in the absence of imaging? First of all, I mean, also the Frankfurt colleague anticipated that the vast majority of the patients are going at least the stable to have CT scan as much as possible before PCIs. So we can look at the CT scan results like in this report, or we can by yourself analyze it using, I mean, the best standards we have, and these are fantastic images provided by Carlos Collet and Patrick Serruis showing the potential that should be explored, should be incorporated in our way of performing PCI in the absence of imaging. What to do during PCI? Well, we have standardized the technique. This is very important because to have a plan is extremely important. So in the case, for example, we perform provisional, we should have in mind which is the best way of doing, and we should have dedication during our procedure in checking, in meticulously applying all the steps, and the systematic application of the technical steps reported for the selected technique is mandatory to translate the technique which is intended in a final results that resemble what we anticipate to have. For example, a critical point has been noticed in the October trial was the rewiring phase, a step OCT rewiring check that is extremely technically complex for the image operator. So these are examples, proximal and distal rewiring. You understand that, we can have images that are easy to understand, but it should be really this quality of images. Alternatively, it will be very difficult to understand what's going on. So if we do not have OCT, or we are not able to interpret images or to obtain this kind of images, we should at least focus our attention in the best angiography views. So this is one trick. You can have the jailed wire that is pulled back and the rewiring wire that is in the distality very close to the carina. So this is a guide wire-based check. And other possibility is to add angiography. You see very well that this rewiring wire with the radiopack part is really close to the carina. Difficult to have better, let's say, images and confirmation by OCT. Other aspects are related with the fact that we can see stents like in the left panel, like standard with the standard angiographic view, or by stent enhancement. Why not using stent enhancement as much as possible? And in doing this, it is possible that we check step by step the process of our procedure so that at each step where something is going wrong, we will discover that there is a problem very early and not at the end a procedure where we have nasty conditions to be fixed. This is very smart way to proceed with this. So intraprocedural use of stent enhancement tools is recommended, especially for bifurcation interventions. And with that, we will disclose that, the standard pitfalls of PCIs, like proximal incomplete POT, or just, this incorrect tracing on with, a nasty result in the ostium of the circumflex, can be easily disclosed, clearly disclosed, and we need nothing more to go on, even if we have OCT in the cath lab, to understand that we have to correct this kind of conditions. And conditions like that compare how stent elongation is seen by OCT and stent enhancement. You understand that there are no many doubts about the fact that there is incorrect elongation, shortening of the stent proximally. So probably to add OCT at this stage was not so necessary. So to wrap up with the practice, example from my lab. Young lady, anterior ST elevation MI, borderline hemodynamics. 90 millimeters mercury in the hands of one very, very, very expert operators in imaging of my cath lab, Enrico Romagnoli. This is the angiography. You see definitely that there is some tapering of the distal left main. There is a nasty ostial lesion that involves a little bit the circumflex. So what an expert operator like Enrico did in the night, he did just what he felt to do, and I reviewed the procedure using a QCA. So according to QCA, at this stage, the left main is 3.9, and the circumflex is around 3.4. Then, if you just reopen the flow into the LAD, you have a condition which is completely different. Now, nitrates came, and now you have 4.2 millimeters left main and more than 3.76 circumflex. This is by QCA. Then we discovered something looking at the literature. There is the possibility that these measures by QCA can be adapted. There is this important trial, the guide-test trial, where the operators adjusted the QCA underestimation, providing these calculations that allow us to upload what we have. So size estimation for left main becomes 4.4, and it is 375 for the circumflex. Now, there is the problem of the LAD. I measured it by QCA. It was 2.1, the mid LAD. However, we cannot trust this. we have the branch calculator by EBC. If you put those measures for proximal left main and circumflex, what you have is the fact that the other branch should be like that. So we have a size estimation from the LAD that is at least 2.8. Now, what did the operator in the cath lab? He wanted to manage by provisional. He knew that he had to implant a stent that should do cover up to the left main. So what he did was to implant a 3.5 millimeter stent at low atmospheres, but within the possibility of chart. That is another aspect that we put in the paper, the fact that we have also low atmospheres range, not only the highest atmospheres. Then he performed 4.5 semi-compliant balloon POT, and thereafter, this is the final result. So since he is really, one of the most imaging-oriented operators in our cath lab, and the patient was now stable and was a young lady, he decided to perform OCT. And this is the measures he achieved that are the ones that are really associated with good outcome. And this is the fantastic result he confirmed in the bifurcation. So it is difficult to think that this kind of results, based just on angiography, can be, let's say, ameliorated by the fact that you in a ST elevation MI decided with a borderline hemodynamics to embark in other things before having fixed the possibility to have stabilized the patient. Thank you for your attention.
Thank you, Francesco. Excellent summary. Do we have any short comment or question? Yves?
Congratulations, Francesco. I see that what I brought 2 years ago about the curve, and Fine brought about the balloon expansion curves, is described here much better than me. So much better than me. So we have to remember that in Europe, probably 95% of operators are not using intravascular imaging. This is not a reason to say that they don't have to treat patients. Of course, they have to do. And they have to use, ersatz of guidance, which is related to the fact that QC is undersizing the vessel. And using this technique, we have done that in Massy. I have done the same provocation, I would say, already in Bulgaria last year. You are able to get results that are really excellent, normally. Of course, you miss something, which is the quality of the wall, the content, and probably for the calcium also we need more support from intravascular imaging. So thank you very much for doing that.
Thank you, Yves. Thank you, Francesco. I just want to add that when we discussed consensus last year, we wanted to make part 1, part 2. Angio-guidance, imaging guidance. But then somehow after discussing with the editors, we said let's do separate documents, and congratulations, fantastic work. Thank you.
So, and now we move from angio-guidance to imaging guidance consensus, and it will be presented by Tom Johnson, please.
Thank you. So this is very much work in progress, but I think important to share as it is a consensus document, and hopefully there can be further consensus derived from this morning's presentation. So I present this really on behalf of a consensus working group. Myself and Nieves Gonzalo are co-leading this. So this is the authorship, which is a blend of EAPCI-EBC board members and then members of the EAPCI and a panel of international experts. So I must acknowledge this was based upon when we first submitted the scientific document in 2022, and I think Mervat would suggest she's no longer part of the young committee. She feels older than that, but consequently this was derived from that time. Francesco's already alluded to the fact we're now in a new era. We have this Class 1A recommendation, but as I suggested yesterday, I worry that this is only the first step and doesn't necessarily impact positively on patient outcome yet, because the gap is in our knowledge and our ability to undertake interventions safely and optimally. And so I believe there is still a very long way to go, and Niels will be presenting again later today, but yesterday presented some fairly provocative sub-study data from October. And clearly the unintended stent deformation data is something we all have to acknowledge, where in the OCT arm undertaken by experts, there was still a fairly significant amount of deformation noted, and most concerningly, over half of those cases were left untreated because operators were unable to detect it at the time of the procedure. And where those deformations were left untreated, we had very significant MACE. Where corrected, MACE was 0. Now, clearly these are small numbers, but I think it acknowledges the power of imaging at the time of a procedure, but it is entirely dependent on us as the operator acknowledging those deficiencies. And that in some ways I think plays out when we look at sub-study analyses from all of the most contemporary trials, so starting from March last year with Renovate. Actually, concerningly, the signal there for the use of imaging here, predominantly IVUS, but 3-to-1 ratio of IVUS and OCT, we actually see no apparent effect of imaging on true bifurcation. And yet, in unprotected left main, there's a clear advantage to the use of imaging. If we looked at next in line, Illumium 4, now actually very few patients were actually recruited with an intention up front for 2-stent bifurcation, and hence the very wide confidence intervals, but you can see again no obvious benefit of imaging in the setting of bifurcation. October we've acknowledged is a very impactful study, but actually when we look at the left main analysis, there is no benefit. Now that is muddied by the fact that just under 40% of the angio cohort had intravascular ultrasound used at the time of their left main intervention. So we can't necessarily make full inference from this. But I think the most interesting sub-analysis from October, and clearly this is kind of only hypothesis generating, is we see the impact of OCT, oddly, in the more simple procedures. So with the 2-stent, more complex, which made up about 60% of the entire trial, we see lesser impact. And I believe that's most likely diluted by the fact that the procedures are challenging and we have every chance of disrupting the procedure despite the benefit of imaging, which is what we see from the unintended stent deformation study. If we look at the most contemporary, so Occupy, again, oddly, we see here actually bifurcation failing to show full impact. And yet, again, we see that in left main, perhaps a more standardized, larger left main where operators actually have kind of a greater standardization to their approach, we can demonstrate the benefit of imaging. But really what I want this slide to highlight is that despite these fantastic tools, there remains some degree of variability in terms of the outcome we might achieve. And so we need to be standardizing as a community the way in which we use these tools and optimize the use of these tools, which at present we still haven't yet achieved. And that's the primary purpose of this document. So I'm just very briefly going to outline two components of the document, which are where the bulk of actually the discussion and the content comes from in the document we hope to be publishing early next year, which is focusing very much on the pre-PCI, so lesion significance, for which Chima has done a huge amount, then thinking about the importance of lesion morphology, and beyond that, how we might use imaging in the planning of our stent, both in terms of technique and then sizing. And then clearly there's a very important role in terms of the use of imaging in the post-PCI phase to ensure that we get adequate optimization. So this is a graphic that we introduced into the second part of the imaging consensus, which was led by Giulio Guayumi. And obviously at this point, this acknowledged the fact that we have some data from different regions of the world where actually these absolute thresholds vary. And so we took this 4.5 absolute cutoff, but then with a grey zone in terms of the need for physiological assessment. And so in kind of distorting this is a work in progress in terms of one of the figures from the document, but we might consider that imaging in addition to physiology provides a further assessment of lesion significance. So the importance of then considering the morphology, potentially considering more vulnerable plaque components against a more stable plaque type, in addition to then the physiological metrics that we might use for defining the significance. Beyond that, then we touch upon these different components of the pre-PCI imaging, so thinking about landing zone, the stent technique, the stent selection in terms of caliber, and then stent length. So taking those in turn, this is actually going to be a bit of a challenge. In yesterday's consensus meeting, there was a lot of discussion about the heterogeneity of left main lesions. We have funnel shape, we have diffuse disease, we have sometimes difficulties in determining a true healthy landing zone. And so the intention of the document is it will be a working document with case-based kind of illustrations within a large supplement, enabling colleagues to look and understand the best way of adopting these. This may be the most contentious element, which is, can we use imaging to define our stent technique? Are there, on occasion, features from the imaging that might push us towards considering the use of two stents rather than working through the stepwise provisional approach? And so maybe with greater extent of disease, greater threat of closure of the side branch, we might go with treatment of the side branch first in a culotte, inverted culotte, or even a DK crush type technique. Obviously, one of the key benefits of the imaging is the ability for us to determine stent sizing, and particular, as Francesco showed in that beautiful example from Gemelli, the idea of caliber discrepancy being one that is most frequently observed in the left main, and an understanding of the importance of determining the appropriate stent to overcome that caliber discrepancy. And then lastly, to think about the stent length, particularly the kind of nuanced decision-making in bifurcation in terms of ensuring adequate lengthening for placement of a pot balloon and such like. So these are some of the illustrations we intend to use to kind of standardize this approach for global use. Then I think that the most interesting element, and one that we still haven't yet nailed down in terms of the metrics, is the absolute cutoffs. And one of the concerns certainly I have from a personal perspective is the inadequacy of shifting between diameter selection of stents and areas for optimization. I don't think people can often compute a diameter to an area. So the intention of this figure is to give them a kind of upfront schematic of being able to understand 4 millimeters is 12 millimeters squared. I know it sounds simple, but I think in cath labs this is often something that's overlooked. And clearly we have historically the 8765 criteria of Kang, but in actual fact, there's new data to demonstrate that those numbers might not be so relevant. So at some point we're going to have to come off the fence and give our numbers for those different areas of the left main. This is just a tabulation of the most contemporary data, and the last meeting we had at ESC in London, it was suggested by Lawrence Raber that we actually try and get the data from all of these studies to combine so that we get then some overall feeling for where these MSAs for left main, LAD and circumflex should lie. And this is actually quite an interesting composite of data, 900 IVUS, 300 OCT, and a blend of East Asian and European Western populations. So I think this could generate some very meaningful data. And so for the moment, we're kind of around a 10 to 12 millimeters for the left main. Excel had said 10. We may have to be cautious in terms of not wanting to drive perforation. 7-8 LAD, 6-7 circumflex. So just to summarize, we are in a new place with 1A, but I think this will, I hope, be an important document for the interventional community. Bifurcation PCI remains a challenge, and I'm not sure the community necessarily acknowledge that challenge always. Intracoronary imaging definitely will provide precision, but there's an absolute need for better education, and we hope that this document will provide that. And critically, the messages from the document that the imaging must be used throughout the procedure, and that it requires engagement in order to influence decisions and ultimately impact on patient outcome. Thanks for your time.
Thank you, Tom. Yeah, we have one question from the audience.
Tom, a great presentation. One caveat I think is warranted when you write these recommendations is when you do pre-planning of the left main with OCT, it's important to realize that you need to dilate the left main stenosis before you do the OCT, because what happens when you flush the arterial tree with contrast, you get a lot of contrast, you induce ventricular fibrillation, and then you start out with a bad outcome. And I think it doesn't really reflect in the documents that this is something that you need to be worried about. And it doesn't happen when you do like LAD, diagonal, OCT. It only happens when you do left main.
I fully agree. I think that's a very important component, is acknowledging safety. The one thing I pick up is you allude to OCT. This is an imaging consensus document, so it's both IVUS and OCT. And actually, I think what has to be recognised is that we've seen from Eve, the majority, and from Francesco, the majority don't use imaging at all. Right. But where imaging is used, IVUS is the predominant imaging modality. And the document has to reflect that. So there is going to be a blend of IVUS and OCT imaging within this document, reflecting use across the globe. Patrick.
Yeah, Tom, I have to make two comments. One which is, we'd say, political or legal, I don't know what to use, is that the last 3 years I've been 3 times in court now for colleagues. And it's basically because they did not apply the guideline. One was very obvious, I mean, 3-vessel disease, not discussed with the surgeon, patient died at the time of the PCI. And now I'm in court because I'm an old man with what, blah, blah, blah. Okay, and it's very difficult for me because, you know, when we start the guideline, we avoid the word mandatory and we use the word recommended. That's how I always save the colleague which is in trouble because, but I warn the people, these guidelines, like somewhat in the United States, will become more and more legal. And at some point, if you don't do what is in the guideline, you will be sued by patient because my brother, my father, my sister die in the PCI without consultation of the surgeon. That's an example. Yeah. Now, the second point, your talk is remarkable, and the talk of Francesco was also remarkable because it shows that we are achieving something which looks more and more scientific. Now, I'm biased because I'm coming back from 3 days on vulnerable plaque. You know, that's a meeting that we are holding for 22 years. We are a little bit older than you, with your 20. But, and I think what is amazing today, especially with the PREVENT trial, is that for similar plaque burden, you may have different level of vulnerability. So I think that this club will, in the future, get in this, because you have basically, you have to revascularize, you have the significant, which is a mixture of physiology and anatomy, yeah, and then you have conservative. But for the similar plaque burden, you could move from conservative to treatment depending on the vulnerability of this plaque burden. Yeah. And of course, it's becoming more and more complicated. If you have a plaque burden of 50, but you have a huge index burden on near spectroscopy, what do you do? Yeah. So I think in the upcoming years, you will go in that direction.
I mean, the Star Wars music is very appropriate because it's so far from reality. If we can't get people to compute diameter to area, the idea of being able to define an intraplaque hematoma or a thin vulnerable, thin cap fibroatheroma, we are so far from people being able to do that systematically. Just the final response, the guideline, I mean, this is a consensus document, so it's not going to have mandated statements. It's an expert group suggesting what we feel is best practice. And in some ways, that gives us a greater freedom to suggest things that might be outside what can be evidence-based, which is useful.
Thank you. So, can I make a 10-second comment? Oh, okay. Yeah, so three things. One thing, I come from a country where imaging is available, but it's not universal. It's difficult to use, the patient has to pay for it. So I'll just make two comments. One is I think operator volume is something that we need to incorporate in both angiography guided as well as imaging guided. And legally, we're probably looking at using 2 experienced operators, because I think that makes a difference. If there are 2 operators working together, safety, outcomes, I think this is something we need to look at. Second thing, post-preparation. Imaging, second time is post-preparation. Once before, once post-preparation, and then once post-PCI. I think probably that is something that we need to do. And lastly, we're working a lot on post-PCI physiology. I think it's not really, it's probably a stronger indicator of outcome in the intermediate term than even imaging. So I'll be doing some work on that. Maybe next year we'll get it. Our next talk is going to be angiography-derived FFR for bifurcation lesions, Shengxian Tu.
Thank you, Chairman. Dear Chairman, dear colleague, it's my privilege to come to here. So I come from Shanghai, and this is my disclosure. So study shows that final gel Cybrance FFR is associated with long-term clinical outcome, and lower FFR in Cybrance is associated with poor outcome. But it's technically difficult for gel Cybrance assessment after main vessel crossover standing, and there's safety concern for the where to go through the Cybrance. So we developed the angiographic-based FFR called QFR to calculate FFR from angiogram. The first generation can be performed only in a single vessel without Cybrance. The second generation is applying the bifurcation fractal law, the Muller bifurcation fractal law in the computation. That's why it's called mu-FR or mu-QFR. So mu stands for Muller. So as you can see, all the Cybrance were detected and then incorporated into the computation to reconstruct the reference vessel with step down across the bifurcation depending on the size of the Cybrance. And let me show you how easily this can be done. So your operator need to only need to select the angiogram, and the software is doing the other step automatically for you. So it selected the best frame for analysis, and then the software using artificial intelligence to delineate all the lumen border in the band vessel and Cybrance. As you can see, the mu-FR computation has been complete, and you have the pullback co-logis with the angiogram. And the interesting thing is that you can do some virtual standing, assuming that this, let me see whether this segment is complete revascularized, and you can see the mu-FR in the distal left LAD will increase from 0.72 to 0.92. At the same time, you can also look at the Cybrance. For example, the second diagonal branch, after standing, you will increase from 0.78 to 0.98. So this gives you a sort of indication. So with this tool, we analyzed the more than 1,000 patients with unprotected left main bifurcation lesion from Poay Hospital. So because it only requires a single angiographic projection, so the feasibility in post-op analysis was high. So we were able to analyze more than 90% of the patients. So among them, we identified 13.2% of the patient has a residual ischemia defined by mu-FR less than 0.80. So the patient will follow up for 3 years. So post-PCI residual ischemia was detected in 10% of the 10% in the circumflex artery, and 2.7% in the LAD, and 0.05% in both LAD and the circumflex. And this is the main result. As you can see that the indeed the residual ischemia was associated with poor outcome, also including cardiovascular death and also bifurcation-oriented cardiovascular event in 3 years. But we have to acknowledge that even only one single angiogram is required. It could be difficult in some cases, especially if you have a gel Cybrance at the very ostium. But using intracoronary imaging, you can, even if you have the pullback in the main vessel, you can appreciate that the Cybrance ostium. So we came up with the idea to integrate both the main vessel OCT with the angiogram to have this fusion model and present this technology in Jacques 2015, many years ago. So as you can see that you can really appreciate the sideburns of the angiogram is overlapping with the OCT. That's a good indication of perfect matching. However, there's a limitation there, is that we only assume that there's a linear alignment longitudinally and circumferentially. And this is not always true because of the cardiac contraction. So the cardiac contraction will make the pullback not non-linear. So we further improve this algorithm, and now we can have this new algorithm to do the fusion using artificial intelligence. So it's separated into 3 steps. The first step is initial reconstruction. You do the angio reconstruction and OCT reconstruction. You can also do the plaque categorization automatically. And then we can use the correlation using this artificial intelligence network called Transcan. The Transcan can really align the angio and OCT in a linear fashion. You can perfectly match the sideburns and also in the angulation. So after that, you can fuse these 2 imaging modality. And as you can see from the lower figure there, you can map the plaque categorization on top of the model. And the purple at the sideburns oxygen there, the purple surface indicate that's the lumen taking out from the main vessel OCT pullback. So we are really taking the sideburns sizing from the OCT and then make combination there. So this is one case of the OCT and the angio fusion in the left main bifurcation. As you can appreciate, the angio and the OCT perfectly match at the sideburns, and you can see the purple indicate the size from the OCT ostium at the ostial sideburns. So how to validate it is not easy. So we collect the case with both OCT and CT, because CT is a true 3D data, so it gives you the best angulation of the sideburns and also the position of the sideburns, and also can be reliable quantify the bifurcation angle. So we use them as a reference to validate the fusion. And this is so a few cases, as you can see, that the shape of the 3D reconstruction by the fusion of the angio and OCT looks very similar with the CT. So this indicates the quality of the reconstruction. So in order to quantify the error there, we defined 4 types of errors. So the first one is called in the longitudinal direction. So we call unaligned longitudinal distance, which means that the sideburns should be there, but it's not there longitudinally. And second, we quantify the circumflex direction. So we have an unaligned circumferential angle showing in the middle. So the sideburns have angulation error there. And the last 2 is bifurcation angle using CTA as reference standard. As you can see, the result, we analyzed 216 bifurcation from 67 patients. The result was not bad, so we got a reasonably good result. And although, in order to validate the sideburn sizing from the fusion model, the purple surface, as you can see from the top figure there, so there was outside a layer half transparent there. That was the angio. So the half transparent surface is the 3D angio. And because some overlap and you don't see the narrowing there, so sometimes the half transparent surface is bigger than the purple surface. And we studied the correlation with CTA-derived ostial airway from the sideburns, and also the minimal lumen airway, 1 millimeter distal to the carina. As you can see, the left figure shows that there was more scatter when you correlate with 3D angio with the CT. If you use the fusion model in the green dot there, you can see that the scatter reduced. So we improved the correlation there. That's an indication that fusion with OCT improved the correlation with CT and compared to 3D angio. So ladies and gentlemen, in conclusion, angiography-derived physiology provides significant prognostic value in patients undergoing left main bifurcation PCI, and fusion of angiography and intracoronary imaging provide better geometry at the sideburns ostium for computational physiology assessment. The future direction is to investigate whether the fusion with intracoronary imaging could improve the accuracy of angiography-derived sideburns physiology assessment in bifurcation lesion, and to investigate the performance of OCT-derived MFR for guiding sideburns treatment after main vessel crossover standing. And thank you very, very much for your attention.
Great talk. Thank you very much, Dr. Tu. Presentation is open for questions, comments. Anyone? Do you think there is possible role of using this in, for example, future DCB studies? So
yes, good questions. Yes, I think the intention from our group is to make to be EEG2 to be used in the cath lab, and you can use to for example, in the stent or DCB. It doesn't matter which technology to be used.
thank you. If there are no other, Francesco.
Small comment. So do you think that artificial intelligence might in the future automatically correct, I mean, provided that you give some insight regarding the quality, I mean, and the pitfalls that you have, so that at the end we can incorporate, we can have, after having done OCT, an automatic reconstruction that takes care not only about the limitation of angiography, but also the possible learning of the machine by the fact that it understood that from other cases like that?
Good question. I think that indeed we can see that the artificial intelligence has really playing a big role in every corner of life, and but we have to be acknowledge that there should be so behind it there should be a rationale. For example, now the artificial intelligence is very good for automated contouring and also detect the subtle change there. Sometimes visual estimation is difficult to see that. Artificial intelligence can detect such subtle change. But if you don't have, for example, if you completely overlap in the cyber ostium and there's no chance for the artificial intelligence to detect it, you don't give them any sign. That's also a limitation.
Thank you very much. Exciting data as always. Next talk, Dr. Nagoshi, clinical study of novel technique of removal of jailing struts in side branch ostium. Recorded.
Good morning, Chairperson, distinguished colleagues, ladies and gentlemen. Thank you for allowing me to make a presentation in the EBC 2024 meeting. My title is Bottom Push Technique to remove side branches strut and 3D OCT guidance. This is my disclosure. As a background, these are two patterns of jailing configuration over side branch orifice in LM. The upper figure shows the link-free type. The distal guide are reclosed with subsequent KBT removes the jet strut completely. On the other hand, lower figure was the link-connecting type. The stent link located at the middle of carina, so kissing with the distal guide reclose causes the severe stent deformation. Distal guide reclosing is not always optimal. In such a situation, the proximal reclose and KBT might be better in terms of the stent deformation. However, the proximal reclose with KBT could not remove the jet strut around the carina. So I wondered if there was a way to make the stent strut inverted at carina. I performed the bench test. The lens was implanted with the stent link located at the middle of carina by checking from side branch using microscopy like this. And with the proximal guide wire reclose and the dilated balloon was pushed towards the side branch direction. Kitching was hollowed. You can see the jet strut that inverted at the carina. I reported the first case in the EBC 2017 in part. First case was the LED diagonal case. You can see the jailing configuration was link-connecting type, so guide wire was reclosed into the proximal cell, and the dilated balloon was pushed towards the diagonal direction, and the balloon was passed. Final angiogram good, and the 3D image reveals the jet strut inverted at carina. At 1 year follow-up, angiogram was good, and the 3D image reveals the good neointimal coverage around the bifurcation segment. I think the procedure is applicable to link-connecting type with the stent link located around the middle of carina, link-free type, where distal guide wire reclose is difficult, and where distal jet strut. We have performed this technique in 51 cases and reported the success rate of the procedure. We defined the procedure success was about 1 crown length distal shift by the procedure, like this. Inversion into main vessel lumen, no or insufficient shift as a procedure failure. We classified the patterns of the Z strut movement into 2 patterns. Parallel strut type, Z strut shifted distally into the main vessel lumen without inverting, and the under-carina type, Z strut shifted distally under the carina by strut slide or by strut inversion. This is the example LM bifurcation lesion. You can see the stent link located at the middle of carina, so we perform the balloon twist technique with the anchoring balloon in the LAD, like this. And after this technique, almost no gel strut overside branch orifice. This is also LM bifurcation case. In this case, the configuration is link relief type, but the distal guide wire recross was very difficult, so we performed this technique. The dilated balloon was pushed towards the left circumflex direction, together with guiding catheter like this. And the final angiogram is good, and the 3D image reveals no gelled side branch, no gelled strut over side branch orifice. Among 51 cases, ACS 15 and LM bifurcation lesion 22, true bifurcation lesion 19, true bifurcation hole, and the side branch difference diameter 2.5, and bifurcation angle 65 degrees. And the push balloon size was 2.5, push balloon pressure about whole atmosphere, and among the port and balloon anchor were performed in about 60%. Guide wire recross point, in terms of the guide wire recrossing point, proximal recross is 65, distal recross is 35. Configuration is in configuration, Linc-connected type about 60, Linc-relief type about 40. Among 51 cases, 39 cases were success and 76.5%. Among the success cases, parallel slide type 43% and the carina type 33%. Among 51 cases, only 2 cases was inversion into main vessel type. Factors related to the procedure failure, bifurcation lesion, side branch difference, larger side branch difference diameter, and a smaller balloon hole push. Complication, in terms of complication, no procedure complication like the balloon stuck and rupture, and a side branch dissection was confirmed in 21 cases, but all is the type A and type B, no acute and chronic occlusion of the side branch. In summary, the balloon push technique is a unique and useful technique for removing gel stent strut without causing severe stent deformation in the bifurcation stenting. With a success rate of 76.5%, the procedure was applicable to the Linc-connecting type, to the Linc-relief type, when distal guide wire recrossing was difficult, and 2 case failure of far distal gel stent strut was present. Strut removal patterns were classified into 2 types, the parallel slide type and the under-carina type, occurring in 43% and 33% of cases respectively. Bifurcation lesion and lower pushed balloon side branch artery ratio contributed to procedure failure. Thank you for your attention.
Thank you. I don't know if Dr. Nagoshi is connected now or not. Yes? Dr. Nagoshi, are you connected now? Can you? Okay. Thank you very much for connecting, and thank you for excellent presentation. If you have any questions or comments, please let me know, how do you correct final stent deformation? Do you perform routinely kissing, or what are the steps after pushing the balloon into the side branch? Is there any mandatory sequence of steps following?
Thank you very much. I usually perform the final kitchen balloon inflation after this technique, but I think this technique don't cause the severe stent deformation.
Yeah, we have a question.
Congratulations for the excellent presentation. I noticed in one of the cases that you were using anchoring balloon in the main branch, and afterwards you presented that in 61% of the cases you were using anchoring balloon. I guess that means that you are using 7 French for this technique, right?
Thank you very much. In most of the cases, I usually use 7 French guiding catheter. So I think with the 6 French guiding catheter, this technique is applicable. But 7 French catheter is better.
Dr. Desai?
Yeah.
Okay.
Is he talking about a standard size side branch dilatation with 2.5 in irrespective of the size of the side branch?
I usually select the side, push the balloon size in reference to the side branch difference.
Yeah. Do you do high pressure stenting of the main vessel before you do this pushing? Do you deploy the main vessels under high pressures? So what pressures do you deploy? More than nominal?
Yeah, we usually implant the stent with a nominal pressure, and before this technique, I usually perform pot. Pot is important before this technique.
Wonderful presentation, Dr. Nagoshi. And I was wondering, what balloon do you use? Use a compliant or a non-compliant balloon for your balloon push?
Both balloon is okay, but I often use the non-compliant balloon.
And balloon length that you use? The balloon length. What length of balloon? Yes.
Length. Okay. Maybe short length balloon is easier to cross. But sometimes I usually use the balloon 12 millimeter length. So such a length of the balloon is applicable.
And in few cases you use scoring balloon. What was the reason to select scoring?
Because we usually use the balloon to which used for the pre-dilatation. So I use the pre-dilatation scoring balloon, so I used it.
And then you use balloon that is already on the table. Okay. Thank you very much. Excellent presentation. Looking forward to see you next year. And the next presentation.
Yeah, very interesting presentation. And the next one is how to manage Linc-connected type jailed side branch for optimal dilation. Will be presented by Dr. Kume. It's also recorded, yeah.
Dear Chairman, thank you for the invitation to present at the EBC 2024 meeting. The title of my presentation is How to Manage a Linc-connected type jailed side branch for Optimal Dilation. For the background of our study, jailed stent strut at side branch ostium might cause lumen narrowing of side branch ostium due to neo-intimal proliferation at follow-up. Therefore, when considering from a long-term perspective, we should avoid stent jailing at side branch ostium as much as possible for side branch blood flow at chronic phase. We previously reported that when the stent link connected to the side branch ostium, there was a significant narrowing of the side branch ostium due to neo-intimal proliferation in the chronic phase. Recently, this condition has come to be referred to as fenestrated restenosis. To address this issue, we have conducted various stent bench tests so far. As for single crossover stent implantation in bifurcation lesions, our previous bench test showed conventional balloon dilation for side branch opening might cause stent deformation toward the side branch, resulting in an incomplete stent apposition, especially at the opposite side of the side branch ostium. We previously reported that proximal balloon edge dilation, pivot technique for side branch opening, might minimize stent deformation like glider balloon. Previous studies showed that link-connecting type immediately after main branch stent implantation was significantly associated with a higher jailing rate at the side branch ostium, even following kissing balloon inflation. On the other hand, a link-free type with distal cell rewiring was significantly associated with a lower jailing rate like this. Considering these results, stent link location significantly influences stent deformation during the side branch dilation. Therefore, we conducted this stent experiment to investigate the influences of the jailed stent link. First, we performed crossover stenting using the previously mentioned bifurcation vessel model with a giant stent. Using video scope, we intentionally set the absence or presence of stent link on the carina, link-free type or link-connected type, and compare the stent parameters after pivot procedures with nominal balloon pressure. This slide shows the result of stent parameters. As you can expect, link-connecting group showed that the side branch jailing rate was significantly higher than link-free group. This slide shows representative 3D OCT and videoscopic images. As you can see, residual stent struts were observed even after side branch dilation using pivot technique with nominal dilation pressure in the link connecting type. So what should we do if a link connect occurs after main branch stenting? To answer this question, we conducted this stent experiment. We intentionally made all the giant stent link connected and compared the stent parameters among the different balloon dilation numbers of times, 1 times or 3 times, and the different pressure, nominal or rated burst pressure. This slide shows the results of stent parameters. The jailing rate was significantly lower in 3 times balloon dilation with rated burst pressure than in 1 time balloon dilation with nominal pressure. Increasing the number of inflations and the balloon inflation pressure could have led to an increased incidence of incomplete stent apposition, especially at the opposite side of the side branch. However, this was not observed using pivot technique. Other stent parameters, including stent area and ellipticity ratio, were similar among the 4 groups. This is a representative image obtained through videoscope showing the ostium of the side branch. As you can see, jailing rate was significantly improved after pivot procedure with 3 times rated burst pressure. To summarize, the jailing rate was significantly lower in 3 times balloon dilation with rated burst pressure than in 1 time balloon dilation with nominal pressure. Other stent parameters, including incomplete stent apposition, stent area, and ellipticity ratio, were similar after the pivot procedure among the different balloon dilation numbers of times and different pressure. There are several limitations in this bench study. In conclusion, in the pattern of the Linc-connected type, pivot with 3 times balloon dilation of latent burst pressure might be preferable for reducing the gelling rate at the side branch ostium. Thank you for your kind attention.
Thank you. Let's see if Dr. Kume is connected. Seems he's not. Professor Ruiz wants to comment. But this is just the extension of what Yves said. With repeat balloon inflations, you reach bigger diameter.
No, first it's quite extraordinary to see that Takayuki Okamura was in Rotterdam between 2009 and 2011, and the whole process of the OCT to judge what we do in bifurcation. I present that in 2010 at the ABC. So it is extraordinary to see the progress. But one thing which is very important, you have to know your device very well. You have seen some of these pictures was Ultimaster, which is very, very peculiar when you want to recross. Then we saw in the benchmark, we saw the science. But I think you have to know very well your device. For instance, if you do with the supraflex screws, you have these longitudinal Z connectors. So you have really to think and try in advance. You will be surprised. And I don't know what's going to happen with the bioadapter. The bioadapter will be quite interesting. I mean, can you break some of these connections on bioresorbable in advance at the time of the implantation and get something else? And I was also, we don't talk anymore about specific device for bifurcation, but I saw that Antonio Bartorelli just published 56 cases of Triton in CCI. The new Tritons, if you can say that. So I think maybe in next year we have to reintroduce this type of talk and see what we are going to do with the bioadapter. I think David Erling has certainly some bifurcation in his 2,600 patient for sure. Yeah, it's a very good presentation.
Thank you. I'm a little concerned about the pressures going up to about rated blood pressure. I mean the rated balloon pressure. Because I'm worried about the injury to the side branch. So is there a guide as to downsizing the balloon when you go up to the rated bus, or you go to the 1:1 sizing of this?
I believe he just wanted to show the extremes. Low pressure, 1 inflation, burst pressure, 3 inflations, just to see whether that will progressively enlarge and remove the struts.
So, yeah, so Ajit,
it's a bench, it's not clinical. So.
The extension to what you said just now. So when you, what I do in my practice is when we do high pressure dilation in the right branch ostium, I get the balloon towards the main vessel. Because the side branch ostium is oval, it is not circular. And when you go up on pressures at the side branch ostium, as you pull your balloon towards the main vessel, the risk of injury is less and the advantage of expansion optimally conforming to the side branch ostium is much more.
Excellent. So, and the last talk for the session today is angiography-derived bending angle analysis in left main bifurcation disease, implications for prognosis and decision making. Shengxian Tu.
Thank you, Chairman. Thank you for having me back again. So I just present that we can use angiogram to compute the physiology, but there's more we can do. We can also derive biomechanical assessment. So this is what I'm going to present in this talk. This is my disclosure. So a few years ago, we present the superficial wall strength. So calculate by reconstruction from the 2 angiogram. You can have reconstruction in multiple phase and then quantify the strength and stress at every location. So the superficial wall stress is actually an integration of different components. So mainly two parts. The first part is because of the cardiac contraction. So you have a stretching, benching, and twisting. So it's more like a mechanical force. The other one is more in the radial direction, is the interaction between the blood pressure and the plaque composition. So the blood pressure change will interact with the plaque composition, and you can get the radial strain and stress. So these two are mixing together, so we want to separate them. One is more related to plaque vulnerability, and the other one is more related to mechanical stress. So we present the angiography-derived radial wall strain, RWS. So this is the concept. So if you have a vulnerable plaque behind, and during cardiac cycle, the blood pressure is changing. So we have systolic pressure and to diastolic pressure. The change of the pressure interacts with the plaque composition. So if you have a more vulnerable plaque, meaning that you have more lipid content and also thin cap, then you will see more deformation there. And this deformation is reflected in the lumen. So if you quantify the maximum lumen deformation over the cardiac cycle, that gives you an indication about the plaque vulnerability behind. And actually this information is hidden in the dynamic angiogram, but visually it's very difficult to see that. But if you're using artificial intelligence, if you precisely extract the diameter over the cardiac cycle and perfectly match them, you can quantify the diameter change, the relative change over the cardiac cycle, and you get this radial wall strain. And this has been implemented in the Angio Plus Core software by Postmedical. So after single view MUFR, if you click and if you put angiogram, you can automatically get this color-coded map. The hotspot indicates that the lesion behind this is more vulnerable. We have demonstrated this in a study with the OCT, showing that there was a good correlation between the angio-derived radial wall strain with OCT-defined vulnerable plaque. So with the parameter called lipid to cap ratio. So the lipid to cap ratio is quantified by the lipid burden. So by artificial intelligence, as you can see the figure here, the yellow part, the percentage, the yellow part in the plaque, divided by the cap thickness. So it's a continuous variable to quantify the vulnerability of the plaque. As you can see, there was a good correlation between the angio-derived radial wall strain with OCT-derived lipid to cap ratio. And we further demonstrate that in non-flow limiting vessel, if you have a vessel, if the vessel has a high radial wall strain, then the event rate is much higher. On the other hand, if you really have a normal flow and a low radial strain, then the event rate is very low. So it's safe to defer the vessel, the patient, if you have a low radial wall strain and also MUFR. The second component to quantify the mechanical strategy is called the bending angle. So this is how we calculate the bending angle. For each position, we take 10 millimeter proximal and 10 millimeter distal, and then we estimate the principal direction. So you can calculate the takeoff angle, and then using 180 minus the takeoff angle, you get this bending angle. For example, for the circumflex ostium, you quantify the takeoff angle from left main to circumflex, and then you get the bending angle. I have to stress that this is computation can be different from the bifurcation angle. First of all, you only need to reconstruct the single vessel without the need to reconstruct the bifurcation, because if you want to do bifurcation reconstruction, you need two good angiogram without much overlap, and this is not always easy in practice. So it has high feasibility to analyze the bending angle. Second, for bifurcation angle, it's calculated without including the curvature information at the bifurcation core, as demonstrated in the figure here. But the bending angle does take into account the curvature information at the bifurcation core. So now we have a radial wall strain to quantify plaque vulnerability. We have a superficial wall strain, so integration of different components, and also we have the bending angle. So this can all be calculated from the same angiogram. So radial wall strain from single angiogram, superficial wall strain, and bending angle from two angiographic projection. And the superficial wall strain is the most technically demanding. It can only be analyzed by very experienced operator in the core lab. So what are the correlations? So in order to do that, we also include the OCT in the analysis. So we have co-registered OCT and quantify the lipid to cap ratio as an index for plaque vulnerability. And this figure shows the main result. So the radial wall strain is not correlated with the bending angle. That's expected, because radial wall strain is more indicate the plaque vulnerability. Bending angle is more mechanical force, mechanical factor. But radial wall strain is correlated with lipid to cap ratio, so by OCT. On the other hand, the superficial wall strength is correlated with both the bending angle and also lipid to capillary ratio because in integration of different composition. But the correlation with lipid to capillary ratio is less than radial wall strength. So our advice that for plaque vulnerability it's better to use the radial wall strength. But if you want to quantify the mechanical strength, maybe you should use the superficial wall strength or bending angle. So this is motivated was to do the study to investigate the association between the cardiac motion induced change of the bending angle taking off from the left main circumflex and the risk of the ostial left circumflex in stent restenosis following two-stent technique. The bending angle has been assessed before by 2D angiogram, but we have to remember that the accuracy really depending on projection, so it's not easy to get a reliable measurement of bending angle. So in this study, we are using 3D. So we quantified the bending angle before and after PCI, and also we quantify at the end-diastolic phase and end-systolic phase. So we have 4 bending angle, 2 in pre and 2 and post-PCI. Then we define the bending angle change as a delta C angle. So if you have a cardiac motion-induced angulation change called delta C, and you have a stent-induced bending angle change called delta S. I'm sorry, a lot of names, but it's a very complex study. You see that we have 2 delta, 1 delta C and delta S. So we analyzed consecutive patients from 2 hospitals underwent left main bifurcation lesion PCI, 2-standing technique, and with 1 year's angiographic follow-up. So in the end, we analyzed 101 patients, and 30 of them developed in-stent restenosis in 1 year at the circumflex ostium, and 71 without ISR. This is the baseline characteristic. As you can see, there's no significant difference between these 2 groups, either bifurcation type or QCA or standing technique. There's no significant difference. This is the main result. So we observed that the bending angle change because of cardiac motion before PCI is the strongest predictor. So if you have a change in the bending angle before PCI due to cardiac contraction more than 16 degrees, it clearly shows that it will lead to restenosis with higher rate. So with an adjusted hazard ratio of 11.5. At the same time, we analyzed whether different standing technique to standing technique will influence the angle change. As you can see that the different standing techniques does not have impact on the angle change because of before and after standing. So ladies and gentlemen, biomechanical force have a critical role in stent failure and as well as sclerotic pathogenesis. But accurate in vivo stress simulation remain challenging in clinical practice. Simplified coronary biomechanical analysis can be performed solely from angiogram by characterizing the coronary deformation behavior in multiple directions. Angiography-derived bending angle change induced by the cardiac motion has critical prognostic implication for stent failure, while angiography-derived radial wall strength analysis can help to identify bone envelope plaque phenotype. And thank you again for your attention.
Thank you very much, fantastic, and thank you for attending this year in person. Really, you always bring brilliant new data. Questions? I was expecting Professor Ruiz even sooner.
No, you know, I know Dr. Tu so well. I mean, we had a weekly meeting in Galway for some times, and all 3 we have been working with Hans Schreiber. So every time he's presenting something, it's always high level, yeah, and complex. I'm sure it's sometimes too complex for the audience and for myself, but we really appreciate. So about the strain, because he mixed the 2 topics, the strain and the bifurcation. The strain, the criticism that I had at that time is that the resolution of the angiography is about 200 microns, 0.2 millimeter. So you measure something which is 0.23, 26 in the range of things. But the big advantage of the angiography is that you don't have the to and fro motion. When you look at the strain with OCT, the OCT is pulled back, that's one thing, but the systole and diastole. So you never interrogate exactly the same level. With angiography, you can do that because you move with your target. So that's a big advantage. We do now stationary OCT in a model in human coronary artery fresh that we get from the coroner. And then we do stationary OCT, so nothing moves, and it's amazing to see the strain of the vessel, even in diseased vessel. I don't think that the angiography is the perfect technique. I don't know how to get stationary OCT in the coronary artery, but it's a very nice topic, and we have to follow if it has a value clinical. Now, the angulation, you remember that I present the 5 years follow-up of syntax, and it took a long time. That was a paper of Chris Girazis in Jacques intervention, if I remember well. And it's interesting is that when you do what we call wrongly provisional stenting, which is provisional, when you do one stent, you maintain some angulation in systole and diastole, and it seems to be good. It seems to be good. When you put two metal, double crush and this kind of thing, there is no more systolic and diastolic motion. And you know, the systolic and diastolic motion seems to be important. If you look at the last ESC meeting with David Erling presenting the bioadapter, okay, you see things, the pulsatility come back. So it might be interesting to see if that technology in bifurcation is going to maintain something, liberate somewhat the systolic and diastolic motion in systole and diastole, because apparently Mother Nature doesn't like the rigidity of two stent and the double crush and so on and so on. Yeah.
Especially at the left main.
Especially in the left main. I mean, the work that we were presenting was only left main. Yeah. Yeah. Very, very interesting data. Yeah.
One more question, Dr. Chico.
Congratulations for the excellent work. I think it's the first time we prove something that all the interventional cardiologists intuitively had done for years, which is avoiding stenting hinge points at potentially high mechanical stress. And I think, I don't know if you agree, probably this is pointing out the spots where drug-coated balloons may be especially advantageous as compared to stenting. Because I guess if you treat the lesion with a drug-coated balloon, this mechanical stress, this hinge point, probably will have less effect in the stent failure that the lesion will have if we stent it.
I completely agree with you. I think that with this study, we also hypothesize that the less rigid stent, so it's more comfortable stent, would probably better to implant it at the circumflex altitude. And Professor Saroy, I think thanks for the comment. I think when we first proposed this technology, it's difficult to believe, as you say, that the resolution is close to what we are going to detect. So the normal angiogram, if you quantify them, is like in 1 or 2 pixel change there. So the original angiogram, the resolution is about 100 micrometer, but sometimes we export them in a low resolution. So actually you reduce the resolution there. So it's better to implant in the original DICOM data instead of exporting them. Second is that if we look at those with high deformation, the really large lipid core and the vulnerable plaque there's more than 2 or 3 pixels. So we can go to 3 or 4 pixels. So in that case, you can quantify them. But you have to be very accurate in the quantification. It's not about the lumen size, but to matching them. You really need to have a good algorithm to co-register the different cardiac phase, and that's not easy. We have spent several years in this, to developing this, and now we think it's comfortable to bring to the society. Yeah.
Fantastic. Thank you very much, Sanvin.
Thank you.
I would like to thank co-chairs, panel, and all the speakers, and would like to invite Prof. Serus for CT scan session.